It's my pleasure to introduce our next speaker, Associate Professor Rosemary Nixon from the Skin and Cancer Foundation. Now, for those of you who don't know, Ro is certainly Victoria's foremost dermatologist in terms of contact.
Sorry, go ahead.
In terms of contact dermatitis, as well as many other fields of dermatology. Anytime you go to see Ro, pretty much all her practice as doctors in Melbourne who just only go to see Ro Nixon. So if you've got some problem with your skin, try and get in, but the wait list is about 2 years. However, we've had a very close relationship with Ro over many years, and in fact at the Austin we send all our patients who have any skin problems, we only send them to Rosemary. And with that we've published a couple of papers on the issues with hand hygiene, various hand hygiene products, and today she's going to talk to us about contact dermatitis to hand hygiene agents. Is it a problem?
Honoured to be here, and thanks to all of you for giving up your Sunday mornings. Fantastic, you didn't go on the run. And also lovely to see some of the referring doctors and nurses who have supported us over the years. So I just want to tell you a little bit about our clinic, our occupational dermatology clinic. So people come along to us with a rash, and it's our job to work out what the rash is and take it from there. So it's a pretty sort of non-specific rash, that's just hand dermatitis for us. We have to make a diagnosis, and in a conventional way, history examination or exposure assessment, talk about that. Patch testing, the test we do to make this diagnosis. We'll try and go a bit faster because it'll be on the website. We have to take a really good history. So this is very much a medical area where we really want to know all about the details. How long they had it? Who have they seen? What treatments did they have? Did they get treatments from the next door neighbour, the chemist? How does it relate to work? Do they have immediate symptoms? Does something burn the skin, sting the skin? Do they have wheezing? Do they have cough? Is it more than just a skin problem? Have they had skin problems before? Have they had eczema, asthma, hay fever? What allergies do they think they have? Are they allergic to cheap jewellery? Nickel, most common allergen for us. Problems with gloves, sticking plasters, tapes, drugs, animals, foods, all sorts of things we need to know about them. What's their history? What medication? What do they actually do at work? Sometimes what they do at work is not necessarily what is told by their job title. Hobbies, household activities, and you'll hear us talk about baby wipes. We've had this epidemic to a preservative in baby wipes. They're big for us at the moment. What does the patient think the rash is due to? So we then have to get an idea of what's happening, what's touching their skin. We can get that obviously from the history. People come to our clinic with all sorts of samples of products. We can look at the labels. Often they'll come in with lever arch folders of material safety data sheets. We have to plough through them. We look at websites. My colleagues overseas in Malmo, they don't bother looking at the data sheets because they have a laboratory. They can just analyse stuff in their mass spectrophotometer. In Toronto, they have an occupational hygienist that concentrates exclusively on this history taking. Workplace visits we get to do occasionally, but they're expensive in our system. But what's revolutionised it is people taking photos of their workplace. So this is not perhaps so important for healthcare, but when they're in a factory, when you say, what do you do? And they say, well, I make this widget out of this gadget. And well, what are you actually making? This is a photo from some years ago. Seriously, Laverton, a tannery, and that sort of green stuff on the ground was chromac solution. It's an allergen and an irritant. So the next thing for us is looking at the skin, trying to get a diagnosis from the morphology. Basically, eczema dermatitis, as you'll hear me say, it's impossible to distinguish. But there are some other non-eczematous rashes that we can, such as psoriasis, such as tinea, granuloma annulare, porphyria cutaneosa, scabies. So it's a little bit of a game. We have to look at the rest of the skin, very important to examine the feet. Sometimes we can get clues of what's happening on the feet with some of these rashes. So we come up with a sort of a list of common rashes on the hands, so that gives us a bit of a help to try and make a diagnosis, and these are some of those rashes. We've developed an algorithm which is very helpful over the years. And basically people come in with a rash and we need to make a diagnosis. So the sort of basic thing is this rash coming from inside your body? There's actually 4,000 dermatology rashes, 4,000 skin rashes. So the common ones for us are eczema and psoriasis, but there are many others as well. We then go to this side and we want to know if the rash is, if you like, coming from inside or if it's coming from outside. It's coming from something touching the skin. So we call that contact dermatitis. This contact dermatitis can be two types. It can be irritant contact dermatitis, and this again is largely a hand problem. So we have things like water, wet work, wet, dry is very irritating to the skin. Soaps, then physical factors like heat, hot water, sweating from occlusive gloves, friction. And then we have allergies, and a little bit complicated. We have two different types of allergies: delayed hypersensitivity, which is what I do, and immediate hypersensitivity, which is more what the allergists do, looking for causes of asthma, hay fever, food allergies, but there's a bit of a crossover as well. We then do testing, we find out what people are allergic to, and then we make a diagnosis. So more about that. We're not actually very good at clinically differentiating the causes of contact dermatitis. So someone comes in, these rashes are actually pretty non-specific, and so we actually often have to test people. And in order to prove how bad we were at making a diagnosis, I unfortunately had to subject myself to critical examination. And I found that in only less than 70% of the cases could I sort of look at someone and say, look, this is definitely irritant contact dermatitis, or definitely allergic contact dermatitis, or definitely eczema. It's very hard to make a diagnosis. So when my colleagues don't send me people to patch test because they know what the diagnosis is, I'm always very sceptical. So we've got history, exposure assessment, clinical examination, and the next way of making a diagnosis with patch testing. So this is what we do in our clinic. So patch testing, it's a test for delayed hypersensitivity. We put on these tests on the back for 48 hours. Now we don't have to scratch the skin. We're interested in an immunological reaction which starts in the epidermis. These tests stay on for 48 hours. Then the tests come off and we rate the spots according to guidelines, and then they come back 2 days later. The next thing is, once we've got a positive test, what does it mean? We have to then interpret the test and interpret what it means. So we classify reactions as either being relevant to the patient's rash or of past relevant. A classic example would be someone that got allergic to nickel in their cheap jewellery and their ear piercing. Or sometimes we just don't exactly know what the relevance is and where the patient's been exposed. So to actually make a diagnosis of allergic contact dermatitis, we need this clinical history of dermatitis, we need a positive patch test reaction, and we need a history of exposure. That reaction is relevant to the dermatitis. If there's none of that, we just call it contact allergy, which means they've been sensitised, but we don't know the relevance of it. If, on the other hand, the patch tests are negative, therefore we've excluded allergy, the default diagnosis is often irritant contact dermatitis, or perhaps a form of endogenous eczema. And one of the things that our group's been very strong on over the years is making the point that actually multiple conditions often coexist. People often have multiple contributing factors to their skin condition. So again, we go back to this algorithm which we use for educational purposes in the clinic. The next type of reaction we need to consider is these immediate reactions, or type 1 reactions. And while these are important for the asthma, hay fever, as I mentioned, there are a number of substances that cause what we call contact urticaria, that is, on skin contact, they cause immediate redness and burning. And the classic, of course, is natural rubber latex. Many of you are old enough to have lived through the latex epidemic in the 90s. Ammonium persulfate is another one, hairdressing bleach, and then there are other inhalant allergens as well. Chlorhexidine does cause a type 1 reaction, although rarely. So these present with an immediate reaction which often resolves fairly quickly, but repeated episodes can cause a dermatitis, again, that is indistinguishable from allergic contact dermatitis from irritant contact dermatitis. So we have quite a problem with the clinical diagnosis of these conditions. We can do prick tests or RAS tests for this sort of allergy. That's an example of a prick test reaction. So when we come to treatment, a lot of the treatment is actually about making a diagnosis so we can work out how to avoid allergens. And of course we love this area because we can actually treat people. I did a talk recently, how to cure your patients without surgery or drugs. We can make a diagnosis, we can get people to avoid what they're allergic to and make them better. So it's a great area of medicine to practice. None of those drugs like you have in infectious diseases. The treatment's very much skin protection, skincare, and Mandy's going to talk all about this. And then the prescription treatments, topical steroid ointments, calcineurin inhibitors, physical treatments we use a lot of, ultraviolet light. We have a special form of very superficial radiation at the Skin and Cancer Foundation, it's fantastic, called GRENS. And then we have systemic therapies, which unfortunately sometimes need to use. Just to give you an example of the sort of person we see, a 51-year-old male nurse, a night shift supervisor, with a 20-month history of dermatitis, predominantly on his dominant hand. He thought it was latex, of course, this was a few years ago. Got better off work, good work-related history. He was atopic, and long referring letter from the dermatologist just showing that the semantics are often an issue in this area. I thought it was an irritant contact dermatitis. I thought that he'd been doing this job for a long time, a bit of a cumulative element. We sometimes see that people just work in some occupations and they've just got, their hands just give up after a long time of exposures. But on patch testing he reacted to heaps of stuff. Coconut diethanolamide is an emulsifying agent, we'll learn more about that. Formaldehyde, lots of his microshield products, fragrance, chlorocetamides, preservative in a particular type of popular redwood sorbeline lotion. Composite, it's a plant extract. He wasn't allergic to latex. So putting that all together, he had multiple things going on. I felt that the primary cause of his problems was allergic contact dermatitis to the coconut diethanolamide in his microshield products, but he also had allergic contact dermatitis into formaldehyde, which at that stage was in the microshield Angel hand gel. He had irritant contact dermatitis from the wet work, that's sort of a given. Possibly allergic to fragrance, possibly allergic to chlorocetamiide. What was interesting with all of those allergies, his rash wasn't that severe, but then the penny dropped that he was a night shift supervisor. He probably actually didn't do that much clinical work, but enough. He was like the boss. So it's complicated, but unless we list all these conditions, all these contributing factors, these diagnoses, then we can't actually get him better because we have to actually work out all the factors that are contributing to his condition. And oftentimes there's stuff at home too. I mean, if someone has 4 kids under 5 at home, then they've got lots of stuff going on with their skin. So basically we're making a diagnosis, we're using patch testing as a technique in diagnosis, and sometimes we need to do prick testing as well. So if we look at the impact of occupational skin disease, and this hasn't quite come up, but basically prevention is our priority because we have all these different areas being affected: quality of life, costs, indirect costs, and of course the public health aspect. And healthcare workers are the largest group in this regard. We have to look at prevention. So healthcare workers are a high-risk group for occupational skin disease because of all these exposures, hand hygiene requirements, use of gloves, cleaning agents, and then the specific tools of the trade such as acrylates in dentists. And there are many studies worldwide which show that there's quite an appreciable incidence of contact dermatitis, of occupational dermatitis in healthcare workers. So we've reviewed our clinic data over 22 years just recently. We had 685 healthcare workers assessed in our clinic and 555 were diagnosed with a work-related skin disorder, predominantly nurses, but also a smattering of doctors, scientists and dentists. Basically they present with hand dermatitis, but interestingly sometimes this can be generalised, particularly sometimes if you have a good going allergic contact dermatitis, it sort of spreads all over the skin. There may be airborne factors involving the face. Briefly, and people could have more than one diagnosis, 79% were diagnosed with irritant contact dermatitis, 50% allergic contact dermatitis, 37% had eczema. So often people who have a background of eczema go into an area such as healthcare and find that their skin is very much irritated by all that hand washing. Latex allergy. Contact urticaria, other things other than latex, often called hexidine. 2/3 of people had multiple contributing factors to their skin condition, and 27% had lost time from work. With the irritants, wet work is a big factor, hand cleaners, environmental factors, but the diagnosis of irritant chronic dermatitis is very much a subjective one. We can't test that. We can really make that diagnosis by excluding allergy, so it's a subjective diagnosis. On the other hand, we can say a lot about allergy because we can diagnose this very, very accurately. So the important group at the top are rubber chemicals. So rubber consists of accelerators, which give rubber its properties of sort of being elastic. So we have latex, which is a rubber protein, and then we have rubber chemicals will be in both latex gloves and in non-latex in nitrile gloves, and they'll give the rubber its properties. And over the years, thiram and thiram-related chemicals have been our number one allergen in all works of life. But there are other things, preservatives. We'll go through some of the ones which are relevant for healthcare workers in more detail. We have seen this huge spike of allergies to this chemical methyl isothiazolinone. I'll say a bit more about that. Fortunately, we're seeing less allergy to rubber accelerators over the 20 years. There have been various improvements in manufacturing, so there are less residual amounts of this stuff in the gloves, but thirams and carbamates have been big allergens over the past. What you might need to know about if you don't is that there is an accelerator-free glove called Ansell Micro Touch Nitro Free. It's pink, and it doesn't have those thirams and carbamates in it, and it's a nitrile glove, so no latex. Over this time, we've seen a big diminution in latex allergy. It's not gone though. It's sort of, I say, it's forgotten but not gone. We still see people, particularly people that buy latex gloves from the supermarket. So not so much in the healthcare sector, more in the sort of aged care and other areas. Preservatives are the big one. So there are a lot of different preservatives. We need preservatives. Anything that's water-based is going to need a preservative, otherwise it'll go bad. So we have formaldehyde and formaldehyde releases, but it's this particular one that's been this methyl isothiazolinone, which we've had something like 20% of people attending our clinic being allergic to this. It's the biggest epidemic that I've seen in contact dermatitis in my lifetime. And there are a number of products in the hospitals, as you can see, that have methyl isothiazolinone. As I said, it's been huge in baby wipes. It's now pretty much been taken out of with a lot of lobbying from us. But there are still a lot of products out there, and it got to the stage that anyone that comes with a history of contact dermatitis, we say, look, avoid methyl isothiazolinone and then come for testing because it's so likely that they'll have problems. There are other excipients in hand cleaners which have caused problems, such as coconut diethanolamide, which I mentioned, and lanolin, and then of course the antiseptics. And we've termed these the hard-to-avoid allergens. And this is quite a problem because a healthcare worker is doing their job, they're washing with whatever's been provided by the hospital, and they're getting allergic to stuff. So that tells you it's the responsibility of the manufacturers to take out stuff which can cause allergy, particularly when you're dealing with people who have a damaged skin barrier because they've had to wash their hands a lot. So when we've reviewed our causes of allergic contact dermatitis, we've actually found a variety of predominantly micro-shield hand cleaners being the top causes of allergic contact dermatitis. And there's been this sort of thing about social hand washing that, you can use these things and they're fine. And I mean, they don't have any antiseptics, micro-shield skin cleanser, but it has a lot of other things that can cause allergies. When we compare the rate of allergies to those products compared to alcohol-based rubs, we find that we have an 8 times rate of allergic contact dermatitis to those hand cleansers than the alcohol-based hand rubs, which are often fairly simple preparations, and with alcohol very, very, very rarely being an allergen. So we can say quite categorically that alcohol-based hand rubs are much better in terms of allergy for the skin, that hand cleansers do contribute to irritant contact dermatitis. But the problem is that alcohol-based hand rubs do cause stinging, and so people tend to perceive that as being allergy, and Mandy will talk more about this, and then they stop using them, and then they go back to the hand cleansers, which have actually got more allergens in them. And as Lindsay said, we collaborated years ago looking at the fact that there were less rates of reactions to hand hygiene solutions than the traditional stuff. So my conclusions, we see these hand rubs causing substantially less allergic contact dermatitis than the commercial hand cleaners. Stinging does not equal allergy, so we have to explain that to our healthcare workers. We had a lot of reactions to so-called hard-to-avoid weak allergens present in the commercial hand cleaners, and obviously it's important that the manufacturers understand that they've got to get rid of this stuff. Rubber glove chemicals have been an issue, but they're less of an issue now, and we've got to look out for this chemical methyl isothiazolone. Overall, we have a significant burden of disease, often mild disease, but nevertheless disease in healthcare workers. So what can we do about it? So at an individual level, there's education and early management. Again, Mandy's going to talk more about that. Secondary prevention, once it's started, we've got to look at allergen avoidance and substitution and use of the accelerator-free gloves. At a manufacturer level, a lot of the some products aren't labelled properly, and we've got to look at allergen substitution. And then beyond, obviously promotion of alcohol-based hand rubs is important, and where we come into is integrating the skincare education with the hand hygiene, and we'll talk more about that. That's, I think, a very important way to go. So Safe Work Australia has supported us to develop some skincare advice into the hand hygiene model. I'm really pleased to introduce Mandy now, who's going to talk more about this. Mandy's a nurse who's done health promotion, worked with me for years and years. I think I'm her only boss. Still comes to work with me from Bendigo, manages our database, manages our clinic, and has been terrific in this area, and particularly in some of the innovations that we've done. So I'll finish with that. Sort of introduce Mandy for you, but you can. Thanks very much.